هنتكلم على الانتراكرينيال انيوريزمز shapes locations and an overview on the subarachnoid hemorrhage. اتفضل يا دكتور بقى.
Good afternoon, dear professors and colleagues. We will review the intracranial aneurysm, shapes, locations, with an overview on subarachnoid hemorrhage. It is a common pathology that 2 to 5% of populations have intracranial aneurysm, with about 12 over 100,000 incidents of rupture. Cerebral aneurysms may result from a combination of congenital, genetic, structural, and acquired factors. The aneurysm shapes may be circular, fusiform, dissecting, or mycotic aneurysm. The most common type is the circular aneurysm that appears mainly at bifurcational points, showing characteristic neck and dome. The neck may be narrow neck or wide neck that will differ in the management. Circular aneurysms are more prone to rupture than other aneurysmal shapes. The second most common shape is the fusiform aneurysm, in which there is abnormal segmental ectasia and irregular dilatation of the artery. It can be treated by either destructive intervention through parent artery occlusion or constructive intervention using flow diverter or stent-assisted coiling. The mycotic aneurysms are rare types, appears in younger age and patients with systemic infection, mainly infective endocarditis, in which the infection spread to the distal cortical vessels, causing disruption of the arterial wall. Blister aneurysms are very small aneurysms, less than 6 millimeter with wide neck, can be missed by CT angiography. Digital subtraction angiography with 3D angiography has high sensitivity in detecting blister aneurysm, which show rapid change in size during follow-up angiogram. Also, traumatic aneurysms are not common intracranial and usually dissecting with irregular configuration. Locations of aneurysm. The most common location of the intracranial aneurysm is at the anterior communicating artery, which represents about 35%. Next, followed by ICA termination and PECOM aneurysm, representing 30 to 35%. Then the MCA bifurcation, representing 20%. At the posterior circulation, the most common site is the basilar tip, representing 5%, followed by posterior cerebral artery and pica aneurysm. In case of aneurysmal rupture, the patient presents with subarachnoid hemorrhage, which is extraaxial intracranial hemorrhage, with the blood seen in the subarachnoid space between the pia and the arachnoid mater. In general, the most common cause of subarachnoid hemorrhage is traumatic, yet the most common cause of spontaneous subarachnoid hemorrhage is aneurysmal rupture, representing about 85%, followed by perimesencephalic hemorrhage, in which there is blood seen in the basal cisterns and usually resolves spontaneously. Other causes include amyloid angiopathy, vasculitis, and drug-induced. Presentations of patients with subarachnoid hemorrhage is variable according to the amount of blood in subarachnoid space, starting from mild or severe thunderclap headache associated with fever or vomiting, and in more severe cases, patients presents with seizures or disturbed conscious level. Patients with subarachnoid hemorrhage complaining of symptoms of oculomotor nerve palsy, like ptosis, diplopia, and dilated reactive pupil, could suggest PECOM artery aneurysm. There is multiple imaging modalities can be used in diagnosis of subarachnoid hemorrhage and the underlying aneurysm. First, non-contrast CT showing the subarachnoid hemorrhage in the form of blood smearing of the brain sulci and basal cisterns, also to detect hydrocephalic changes if present. CT angiography is useful to detect the site of the aneurysm, with the volume rendering images can show the aneurysmal configuration. MRA can be used in selected patients with high serum create. Yet the gold standard remains the imaging modality is the digital subtraction angiography, which shows precisely the site, size, the shape of the aneurysm, and can clearly visualize the aneurysmal sac and neck, to plan the strategy of treatment. Either it will be simple coiling or balloon-assisted coiling or flow diverter. In cases of negative CT brain with highly clinically suspected subarachnoid hemorrhage, lumbar puncture can be done to detect small amount of blood in CSF, and it is positive in about 3% of suspected cases with negative CT brain. Some ECG changes can be seen in patients with subarachnoid hemorrhage as QT elevation, Q waves, dysrhythmias, and ST elevation mimicking myocardial infarction. Multiple classifications are used to assess subarachnoid hemorrhage, either clinically as Glasgow coma scale and Hunt-Hess grading system, or radiologically as modified Fisher scale. Vasograde scale is used to combine clinical and radiological data to assess patients with subarachnoid hemorrhage. Modified Fisher scale can predict risk of delayed cerebral ischemia. It classifies subarachnoid hemorrhage into 5 scale, starting from 0 with no subarachnoid hemorrhage or intraventricular hemorrhage, with 0 risk of delayed cerebral ischemia. Grade 1, patients with thin subarachnoid hemorrhage and no intraventricular hemorrhage, with about 24% risk of developing delayed cerebral ischemia. Grade 2 with thin subarachnoid hemorrhage with intraventricular hemorrhage, and about 33% of risk of developing delayed cerebral ischemia. Grade 3 with 6 subarachnoid hemorrhage and no intraventricular hemorrhage, with about 33% of risk of developing delayed cerebral ischemia. Then grade 4, in which the patient has 6 subarachnoid hemorrhage with intraventricular hemorrhage, showing about 40% risk of developing delayed cerebral ischemia. There's 2 main complications occur in patients with subarachnoid hemorrhage. The first is increased intracranial pressure and hydrocephalic changes as the accumulating blood disrupts the CSF circulation. These patients may need surgical intervention to relieve the pressure using external drain. The other main complication is vasospasm and delayed cerebral ischemia, secondary to breakdown of blood products and imbalance between vasodilator and vasoconstrictor with inflammatory changes. This may lead to cerebral ischemia and even stroke. It is treated by triple H therapy, which is hypertension, hypervolemia, and hemodilution. We use the calcium channel blockers, nimodipine, as oral tablets. It may be used intravenous infusion, and in more severe and resistant cases, being injected intra-arterial castrum. Thank you.
Dr. Baha, for a very interesting lecture. I think we should postpone the questions after the session for the sake of time. Now I'd like to present my dear friend, Dr. Hossam